let's briefly touch base about some possible injuries to the vestibulocochlear nerve. Okay. First off, let's have a look over here. Well, the vestibulocochlear nerve emerges at the junction down here between the pons and the medulla. It'll then leave the cranial cavity via the internal acoustic meatus, where it'll then course and terminate within the temporal bone. That's where the labyrinthine is, and that's where the cochlea is for hearing. All right, there's the outer ear. Let me see, over here. Okay, so what can go wrong if you have issues with the vestibulocochlear nerve? Right. First of all, I think we should appreciate that although the vestibular and cochlear divisions are essentially independent, peripheral lesions will often produce concurrent clinical effects because they are in so close relationship, right? You can see how close they travel together here. So if there was a tumor deformed there or any kind of other lesion that occurs, it is likely to affect both of those, right? So if you have a lesion of cranial nerve 8, you might have tinnitus, which is ringing or buzzing in your ears. And in addition, you would also have vertigo, dizziness, and loss of balance, and maybe even impairment or even loss of hearing. If you have a central lesion, that may involve either the vestibular or the cochlear divisions. If we look at these images here of the middle ear and the inner ear, it becomes a little bit more intuitive that deafness can actually have several causes. Specifically, conductive deafness that would involve the external or middle ear, so for instance the tympanic membrane or the ossicles involved here. That can come, for instance, from an ear infection, so otitis media, which is very unpleasant. And there's sensorineural deafness, which will result from a disease of or in the cochlea or in the pathway from the cochlea to the brain. In addition to that, there is something that's called a acoustic neuroma. So acoustic neuromas are usually benign tumors of the neurolemma of Schwann cells. So the tumor will actually begin in the vestibular nerve while it is still within the internal acoustic meatus. So if the tumor is located at the cerebellopontine angle and presents initially with cranial nerve 8 dysfunction, so hearing loss and ataxia, well, as the tumor grows, you can imagine that it'll involve cranial nerve 7 and 5 as well as it grows bigger and bigger because they are in pretty close proximity. And of course, that will then result in further reaching symptoms like, for instance, loss of facial muscle expression and trigeminal sensory loss. If the tumor grows even bigger, so further progression, that might actually compress the glossopharyngeal nerve, the cerebellum, and also the brainstem, which is when we are really getting into a very, very dangerous area.